As you may know, people with AL amyloidosis, 2/3 of the patients will have renal involvement. And it is estimated that 25% of those patients will subsequently develop end-stage kidney disease, will progress towards kidney failures, meaning that they will need to have a renal replacement therapy to stay alive. And in fact, the risk of developing kidney failure or stage 5 chronic kidney disease is mainly observed within the first 3 years after the diagnosis of AL amyloidosis. And it's directly related to the stage of renal disease you have at the moment we discover the disease, meaning that higher the protein rates, higher the protein loss in the urine you have, lower the kidney functions you have at the diagnosis, higher the risk to develop kidney failure. And so it is, I represent here the scale. I don't know if I have, I represent the scale. You can see the different stage of chronic kidney disease with the white and the dark spots represented in these figures, the filtering units, glomerulus. And you can see that more you go through kidney disease, more the filtering units are damaged by AL amyloidosis. And in fact, most of the cases with AL amyloidosis and renal involvement are a diagnosis at the mild stage chronic kidney disease, meaning that they won't have any specific symptoms except proteinuria and loss of kidney functions in the blood. So meaning that it's really difficult to discover by symptoms the renal involvement by the patient himself. And finally, when do we have to start dialysis? When do we have to talk about renal replacement therapy to all patients? I would say overall, it doesn't differ from patients with amyloidosis or not. For all patients, is when the filtrations capacity, the kidney functions capacity, drop below 10% of the whole capacity. We start with a 100% capacity at start. And so, in the specific context of AL amyloidosis with cardiac failure or cardiac involvement, the patients might require renal replacement therapy even sooner, because in fact there's a tight communications between the kidney and the heart, meaning that if the heart is going is going wrong, it will affect subsequently the kidney, and the other way around is also true. So meaning that sometimes to support the cardiac functions, we have to start renal replacement therapy sooner to support the cardiac and renal communication. So symptoms that might indicate the need for renal replacement therapy, they are very multiple and very aspecific, and sometimes may be confounded by the AL amyloidosis symptoms. An extreme fatigue, short of breaths, the fluid retentions, and severe hypertension of the contrary drop in the blood pressure because of autonomic neuropathic damage, confusion, being less cognitively aware, weight loss, anorexia, muscle loss, and the need to scratch are all the symptoms that means that there are toxins in the blood that are not completely removed because of the kidney function is dropping too low. And in fact, there are two main modalities to replace the kidney functions: renal transplantations and dialysis. Of course, renal transplantations is the best options because it offers the best outcomes for the patients at the lower cost for the society, but also for the patients. But not all the patients will be eligible for renal transplantation, and even if they are, in fact, they have to wait for a kidney transplant became available for them. So that in the waiting periods, they will need dialysis as a bridge to have a kidney transplant. And you can see that in 2024, we have a lot of options beyond in-center hemodialysis. We have a lot of techniques available that normally should fit your lifestyle preference, your values, your belief, but also your specific medical needs and also your social environment. So we have two types of dialysis. I represent hemodialysis with the blood circuit. You can see we use an artificial kidney, an artificial dialyzer, where the blood comes in and comes out when he is purified and comes back to the patient's circulations. That's hemodialysis can in fact occurs either in the context of a hospital or a satellite hospital, when you can see there is a nursing attendance, doctor's attendance, and where the patient normally doesn't participate in any manipulations. In satellite HD units, that's other room where there is less attendance from the nursing staff and less attendance from the doctors, the patients can already perform some manipulations related to setup of the machine or to the connections to the systems. But home hemodialysis may also happen when you have eligibility to perform hemodialysis at home. You can see one of my patients who used a miniaturized device, generators of dialysis, who performed that at home himself, and he's in charge of all his manipulations, meaning setup of the machine, control of the parameters of dialysis, etc., etc. Of course, he can perform his dialysis sessions at home with the help of a caregiver, a family caregiver, of a nurse caregiver if needed. And the second modality of dialysis is peritoneal dialysis, where you don't use an artificial membrane, but you use your own peritoneal membrane as a semi-permeable membrane through which the toxins will diffuse from the blood, from your blood, to the abdominal cavity. So you infuse dialysate 1, 2, thrice or 4 times a day, and the dialysated will saturate in toxin and will be drained out when it becomes yellow. And so this technique is particularly important because it allows the patients to perform that at home without the help of anybody, because it's really simple, but it can also occur and can be performed during the night. So you have two different techniques. You have the cycle machine and the manual exchanges. And so you can perform during the night. And so most of our patients in Europe and still in US, maybe not in Canada, still default into hospital hemodialysis. And it's a bit pity because, in fact, there are many barriers to provide home dialysis, either home HD or peritoneal dialysis. And the main barriers, in fact, is not the patients, it's nephrologists. We're not aware of those techniques, and we don't have always the knowledge to provide this technique and to support the patients and the family to do the technique at home. And in fact, the choice between home dialysis or hospital dialysis, you see my patients who hesitate between the two pathways, will rely on the educations the patient will receive when proceeding and doing the modality selections process, and it will rely on the supports and the educations it will be provided by the staff. And if the nursing and the medical team staff is not skilled enough, confident enough to provide and to inform the patients in a non-biased way, the patient may still too frequently default into hospital setting. And it's a little bit pity because only 10% of our patients are still are only treated by home dialysis, despite established benefits in terms of socioeconomic impact for our society, but also at the viewpoint of the patient, for the patients, in terms of quality of life, but in terms also of cardiovascular benefits. And so I put you some, I listed here some, for me, and from the patient's viewpoint, some established advantages of home-based therapies. It's increased times at home for usual activities because it avoids, of course, frequent journey to the hospitals and from the hospital, from the dialysis centers. It allows you to do a night dialysis schedules, making you free for the day. As it is a personalized approach, it's not standardized, you can more customize the dialysis regimens according to the specific medical need of the patient, but also according to the lifestyle preference of the patients. And it has other advantages, as for instance, it's lower the risk of hepatitis B or COVID-19. And for me, in my opinions, one of the most important advantage is that home dialysis are more continuous techniques, more frequent techniques, more physiological techniques that support a little bit better the cardiovascular systems. And while you avoid the long interdialytic gap between two sessions at the hospital, at home, you are treated nearly every day, meaning that it's avoid the hemodynamic swing and so the impacts and the harms on the blood pressure and the cardiovascular systems. And it's really, I think, important to talk about that in the setting of AL amyloidosis. But of course, home dialysis has also its own drawbacks, and I would say that you need to store the supplies, the materials for performing dialysis, so you need some place. It brings you some logistical workloads. You have to take care about the delivery day, to take care about you have sufficient materials at home. Do you need some extra materials? Some patients may experience fear to self-function their vascular access, but it's something we can learn to make the patients more self-confident in the way he's doing his care. And of course, it's because of the repetitive natures of the treatment. It's nearly everyday treatments. It can also, after 2 or 3 years, have an impact of the emotional state of the patient, with some burnout of the patient, but also sometimes on the family caregiver. And so I would like to illustrate you the modality selections process for one of my patients who suffer from AL amyloidosis. In fact, I saw him for the first time in 2017. He was 60 years old, not known for very severe disease, but at that time we discovered a double hematologic conditions, a B-cell lymphoma, non-Hodgkinian lymphoma, and a myelomultiple with IgA lambda. And in fact, he has anemia and he has renal involvement, already severe renal involvement, stage 3, meaning that he had a heavy proteinuria loss in his urine, and he has also kidney functions decline at about 50% of kidney functions. At that time, at the diagnosis, he didn't have any sign of cardiac involvement, although we did not perform MRI at that time, just an ecography. And so you can see that the biopsy at the diagnosis show extensive pinky, puffy deposits of amyloidose AL within the glomerulus, which is the filtering unit of the kidney. We have 1 million of glomerulus and filtering units, but in fact the glomerulus were diffusely damaged in these patients. And so we start chemotherapy targeting both plasmacytoid cell and B cell. And you can see that he had a strong chemotherapy regimens with rituximab, cyclophosphamide, oncovin, prednisone, and bortezomib and dexamethasone. So he had a very strong chemotherapy. In fact, we were very happy because 6 months later, he had a very good hematological response with a normalized lambda light chains and reduced proteinuria. So at that time, we were quite confident about the futures. But the story will tell not the same story. And in fact, you can see on the left panel that the slope of its kidney functions, you can see that its kidney functions, despite we had an hematological response, continue to decline. With at the diagnosis 45% and 3 or 4 years after the diagnosis, only 20% of kidney functions. And the proteinuria on the right panel, which was really severe at the diagnosis, dropped very well after the hematologic answers and response and the treatment with Velcade, but in fact raised again in 2020. So that we perform a second kidney biopsy to see if there were always still amyloidosis deposits in the kidney. But in fact, there were no new amyloidosis deposits. There were only scars and fibrotic changes, meaning that despite a more or less sustained hematologic responses with good control of the lambda chains levels, we could not delay the progressions of to kidney failure due to the severe sequela and fibrotic scars in the kidney induced by the first but very diffuse AL deposit in 2017. And you can see that this patient, the lambda chains control was quite well achieved because it didn't require any chemotherapy until the lambda chains rise again in 2022, where we proposed a second line and even a third line with 8 cycles with daratumumab alone. Okay, so that's in fact these patients also had cardiac functions that worsens with you can see a severe thickening of the wall of the heart, and also some reduced capacity of the muscles, the cardiac muscles, to relax, so that the muscle, the heart didn't feel in very well. So overall, the situations of the renal situation, but also the cardiac situation, worsens in 2022 with a reduced capacity of the left ventricular blood ejections as low as 30%. And as I explained you, the heart is when the heart's not going well, the kidney is not going well. So both, it is of course a worse prognosis, and the need of dialysis arise. And so at Christmas, the last Christmas, he went at the hospital because he was really short of breath with anasarca. He has a swelling of the legs. He has gained 10 kilos. He could not breathe. He could not gym anymore. And this was refractory to conventional depletive treatment with diuretics. And so at that time, we were very disappointed, and the patient was really in emotional distress because he is scared about starting dialysis. He said, what if I have to stay on dialysis forever? And so we discuss a lot with the patients, because it's quite very autonomous patients, about the pros and cons of each dialysis techniques, the lifestyles, what is the means, what is for him the most suitable options as dialysis options to take him until as a bridge to transplantations. And we decide together, after a long modality selection and shared decision-making process together, to do peritoneal dialysis as a bridge for renal transplantation. And that's the reason why he chose, in fact, peritoneal dialysis, is because it's probably will improve the hemodynamic and cardiac tolerance, as it is bring smoother ultrafiltration rate. It's a more continuous dialysis modality. It allows him to have a personalized regimen, a lighter incremental regimen of dialysis, not intensive one. It has a good potential of salt and water removal, and it has the possibility to arrange his 2 or 3 PD actions to his agenda. And so that's the regimen we propose him, 2 exchanges during the evening with 1 long exchange during the night. And in fact, after 1 month of PD treatment with only 2 or 3 exchanges a day, he lost 10 kilos, his blood pressure dropped, and he restarted.
It's just possible to accelerate.
Yeah. And so that's the kind of dialysis pictures of patients we use. You have the cycler and you have the peritoneal dialysis. And so it's how it's work. You fill in the pure dialysis in the blood and you drain in afterwards. And so there are specific advantages of peritoneal dialysis in AL amyloidosis, because it's a continuous and smoother ultrafiltrations and toxin removal from the body, so that it has increased tolerance from the general hemodynamic point of view, but also especially for AL amyloidosis with cardiac failure or dysautonomy. It has a good potential of large toxin removal, including lambda and kappa light chains. There is no need for anticoagulations, and as my colleagues said before, in fact, there are some problem with coagulations markers, and it has, of course, quality of life aspect because it's less intrusive than the in-center hemodialysis. And what I would like to say is that peritoneal dialysis has not been shown to increase the risk of peritonitis, the infection of the dialysis in AL amyloidosis patients. And that's a study that shows you that the way the intrusiveness of the illness, but also the treatments, the dialysis modality, is significantly lower in PD patients compared to HD patients. It says the home HD patient is just to show you how does it look like. You perform that also 5 days a week with 2 or 3 hours during each session. It's more regular. It's the philosophy is quite the same as PD. That's a recommendation for the treatment. So I will end with these key messages. Is the choice of dialysis modality has a major impact on many aspects of individual lifestyles, and therefore lifestyle, social environment, and personality, as well as medical specific need to be considered in the decision-making process, and the patient should have the right to choose the modality that suits best his lifestyle preference, but also his specific medical needs. And so home-based treatments, because of their smoother but continuous approach in normalizing the body compositions and the toxin content, might be a very good suitable options, especially for those who have cardiac involvement or for those who desire to stay independent or in control of their own life. Thank you for your attention.
Thanks a lot.